Hi, everyone. We're just getting the computer all set up. Thank you for joining. I'm Dr. V.
Hi, Dr. Horn.
And we're going to talk today about asymptomatic bacteriuria and maybe touch a little bit about UTI, but really focus on asymptomatic bacteriuria. We have had a lot of questions on this topic, so we thought it would be really good to discuss it again.
Yeah, I think this is a really good topic. I think I say that every time, but I think we only choose really good topics. So, I've had questions on this recently, and asymptomatic bacteria and urinary tract infections can be kind of tricky. So I think it's a good thing to go over and discuss because we also have some information that you can have for your facilities. I think that's good too, because we were just talking about education for facilities and re-education for the people that order the urine cultures it's hard to kind of keep up with everybody and make sure that they have education available for them. But yeah, I think this is a great topic. If you have any questions while we're talking, please either type in the chat or unmute yourself and ask any questions that you have.
So we're going to start off as, what is asymptomatic bacteriuria? It's the presence of one or more bacteria growing in the urine at a specific quantitative count. So usually in the microbiology, it's more than 100,000 colony forming units, irrespective of the presence of pyuria, meaning white blood cells in the urine, absence of signs or symptoms of urinary tract infection. So basically you have bacteria growing in your bladder in the urine, but you don't have any symptoms. You might have white count in the urine, you might not, but it's just having bacteria in the urine.
Yeah, so the most important thing is, does the patient have symptoms? So sometimes we'll get a call and they'll say, hey, this person is growing this in the urine or that in the urine. And our first question is going to be, oh, what are their symptoms? Or why was the culture taken? And, if they say they don't have any symptoms or they have symptoms that are unrelated, then you can probably just ignore it. Yeah.
So I really like this picture. It gives a really nice view of like where bacteria are. So this is a nice picture of here. We see our rectal area, our colon coming in there. So obviously our stool has millions and billions of bacteria, lots of good bacteria, including, for example, E. coli is part of our stool. So what happens is when you're, especially if you look at the female genital area, these bacteria can colonize the vaginal or the bladder area that is really close by. And they might just hang out there because they can get colonized in that area. And for the most part, we have lots of bacteria in our body, including in the bladder, vaginal, rectal area. So just kind of showing the pathway, for example, if there's an E. coli, it's very easy to get it colonized in the bladder. So if you have urine in the bladder, the E. coli can just be part of that urine and part of that bladder area.
Yeah, so bacteria in the urine is a normal finding. So, and you just think of it just as we're talking about that it's going to be normal colonization. And that's actually a good thing, a healthy thing, just like it's in your gut, just like it's on your skin. And so, you don't want to kind of wipe out the normal flora if you don't have to.
And that's why, let's say that, if we get a urine sample from the bladder here and patient has no symptoms, you might get E. coli, you might get Klebsiella, you might get some other bacteria, but it's not causing symptoms if the patient has no symptoms.
So bacteriuria is the presence of bacteria in the urine, and indwelling catheters can become colonized so easily. Incidence of bacteriuria is 3 to 7% per day. So when urinary catheters are put in place, there's a plastic tube that goes into the bladder, and the bacteria will stick to that plastic tube, just as this picture is showing. And so you've got bacteria here, and then you've got biofilm. And biofilm is an extracellular matrix that the cells make, and it's sticky. It looks like this mucus here, and it helps them not only stick to the plastic, but also protects them from things like the bacteria or from the antibiotics. And so it can be hard for the bacteria or the antibiotics to penetrate the biofilm and get in and kill the bacteria.
So if y'all look here, you know how you could see the biofilm right here, the sticky material, but underneath it, there's lots of bacteria hiding out. So, and if you think about it, if a patient has a Foley catheter, this plastic tube in their urethral area, once you placed it, within the first day, 24 hours, you have like 3 to 7 to 10% of colonization. So in 3 days, you have over 30 to 40%. So if you have a chronic indwelling Foley and this plastic tube is just colonized with bacteria of all different kinds, and you might not be able to see with the naked eye, but it's colonized with biofilm and bacteria. So that is why it's really important to know. Sometimes when people get urine samples from a Foley catheter, and they're like, oh boy, there's all these bacteria, we have to treat it. If the patient has no symptoms, we really should not be treating this type of a colonization. Another thing to remember, what I want to highlight is also, let's say the patient has a Foley catheter in the bladder area, then all of this area now is colonized with bacteria too. So even if you take the Foley catheter out, even if you do straight cath, now you definitely colonize the bladder with the same bacteria. So you're going to get stuff grow more than 100,000 colonies, but if they have no symptoms, they should not get treatment.
Yeah, and when we're talking about symptoms, we're talking about urinary symptoms. So frequency, so they're urinating frequently. Frequency, urgency, like they have to go immediately. There's an urgency to it. Frequency, urgency, dysuria, and the dysuria is pain with urination. Now, if they have a Foley catheter in, they won't have frequency or urgency, and dysuria. You can't really have those symptoms. But if we get a question, hey, they're growing this from a Foley catheter, the question is going to be, is that important to treat or not? Because they're all going to grow something. And generally we'll say, are they having a fever? Do they have a leukocytosis? Is there a reason to suspect it? Or can you just remove the catheter right now? Do they still need it? But if they don't have any urinary symptoms and they don't have a Foley catheter in, you can probably just ignore it. And more the studies are saying, if a patient comes in with symptoms and they're not urinary symptoms, it's not going to be from bacteria in the bladder.
And I really like this chart. It kind of goes through how different types of patient and how much colonization you could have in the bladder with different types of bacteria and have asymptomatic bacteriuria. So if you have a healthy premenopausal woman, you could have asymptomatic bacteria about up to 5%. If you're female, 70 to 90 years old, it could be anywhere between 10 to 15, 16%. Female with long-term care residency. So if you live in a long-term care facility, then you have a chance of colonization goes up to 50%. Both male and female in a long-term care residency. If you're a male or female with diabetes, up to 30%, male with diabetes up to 10 to 11%. Patients having dialysis, 25% can have asymptomatic bacteriuria. But if you look at it, people with long-term indwelling urinary catheter, so Foley catheter, you do straight cath daily, or suprapubic catheter. So all type of foreign catheters can have over 90% asymptomatic bacteriuria, so really high rate.
So if a patient goes to the clinic or goes to the ER with something that's unrelated to any kind of urinary symptoms, we don't recommend checking the urine, because once you check it, then it's kind of like, well, what do I do with this positive result if something's growing from there? So we really only recommend checking with the intent to treat. So if you say, I'm going to treat this patient if they have something in the urine, or I want to know what it is, then you would check it with the intent to treat, but if they don't have any urinary symptoms, I wouldn't check a urine at all.
Yeah, so imagine the patients coming into the, long-term care patients, elderly patients who are long-term, who have indwelling catheter coming in with like shortness of breath or chest pain or headaches, should not have urine sample because, as you know, you see over 90% colonization.
So here's a first question. We have a few questions sprinkled into this one. This is an 80-year-old male. He presents from the nursing home to the ER with fever and found to have pneumonia. He has a chronic Foley catheter in place for over 1 year. If you obtain a urine culture, what is the percent that his urine will be colonized with bacteremia? So what percent of patients with a Foley catheter are going to have something growing in the urine? And
Asymptomatic bacteriuria.
Asymptomatic bacteriuria. So, I'm always suspicious when we get a consult and they say they have a pneumonia and a urinary tract infection, or they came in with a broken leg and a urinary tract infection. So whenever they say and a urinary tract infection, I'm kind of suspicious because if they have a pneumonia, that's what we should be focusing on. And whenever they say and UTI, I'm kind of
Anybody willing
wary
to
of
take
that.
a guess about what is the chance this patient will, what percent of colonization will be in this patient who has chronic Foley catheter? Put it in the chat or unmute yourself.
So with a chronic Foley, it's going to be almost all of the patients. So it's going to be 90 to 100% of patients. So the answer is going to be C. Yep. Excellent.
Yes.
Thank you,
We have
Valerie.
the order.
Yeah.
We're tricking the. Thank you, Valerie.
And then, so this is bacteria in the urine from a person without symptoms, is asymptomatic bacteria. So foul smelling, cloudy urine does not indicate a urinary tract infection. Mental status changes, not a UTI. Pyuria can be seen in patients with UTI, but is not diagnostic of UTI in the absence of symptoms. So, when, and this is one thing that you've done very well with criteria for reflex to culture. So when you do a UA and he goes to the lab, there is an order to reflex to culture. So if it looks like it's an infection, you can reflex it, meaning it looks like it's an infection, so they will do a culture on it. And if it doesn't, they won't do a culture. So some people have criteria, say if it's foul smelling urine, then do culture on it. But foul smelling is not going to help.
So I talked to one of my infection preventionists, and she always says, when did foul smelling urine become an FDA approved indication for urine culture?
Yeah.
So she always reminds me, and I learned a lot from her. So foul smelling urine.
So, and you'd never smell it and say, oh, that smells good.
Yeah.
Like
change in urine color.
Yeah.
Mental status change, even white cells in the urine.
Yeah, or sediment.
Yep. Not all those indications are not good for urinary culture.
Yeah, it's not a reasonable reflex. Yeah.
Treatment, unless you really are worried and concerned.
So in your hospital system, if your hospital has criteria to reflex, you can, discuss it, bring it up in the committees to change that. It's how sensitive or specific you want it to be.
Yeah.
But a lot of these cultures get done when they're not indicated in the first place. And then, so it spends a lot of money on doing something that's unnecessary. And then the patient may get antibiotics for something that's an unnecessary reason to get antibiotics. So it can actually make a big change at a system level, or save money throughout multiple departments for this change.
In us health system, what I worked on a long time ago is to get rid of, when you have urine analysis with culture if indicated, the only time we will have now culture is if you have more than 10 white cells in the urine. And then making sure everybody knows if they truly have symptoms. So we got rid of foul smelling, sediment, all the other different indications.
Yeah, and that's a really good thing to do, because it can make some of these small changes to criteria like this can make big changes. Question 2. So this is a 68-year-old female, comes to the clinic with complaining of fatigue. She discusses with her primary care physician that she recently noted that her urine having a foul smell and sedimentation. She believes her fatigue and tiredness are related to the urine and would like a culture and antibiotics. What would be the appropriate counseling? So you have a patient here complaining of fatigue, and she wants her urine worked up. So for this foul smell and sediment. So what would you say to this patient if they come in? Would you say we need to obtain a urine culture? Foul odor does not indicate infection at this time, and no antibiotics are needed. Referral to urology for a cystoscopy. A 7-day course of PO levofloxacin for a UTI. A 7-day course of IV levofloxacin for a UTI. So what would you say for this patient?
If you could put the answer in the chat box, so unmute yourself.
B. All right, great.
Thank you,
Thank
Jennifer.
you, Jennifer. Foul smell, foul odor does not indicate infection. So that's great. You know, sometimes patients will come in and they'll say, I think I have a UTI. And usually I'll ask them questions like, why do you think you have a UTI? Have you ever had a UTI in the past? And, you know, they may say, oh, my friend has a UTI and this is what, you know, they got antibiotics, so I think I should get antibiotics. But really the thing they want to know is what's going on, what is happening. So sometimes the clinician will think, oh, they just want antibiotics, or all my patients want antibiotics. But some of the studies will say that when they do surveys of patients, the main reason is that they want to know what's happening, and they want reassurance.
Yeah. So talking to the patient and reassurance in this case is the most important thing. So now here we are going to talk about asymptomatic pyuria. So we get a lot of questions when, you know, we get called on, well, this patient, I did a urine analysis, they have white cells in the urine, so now I should give antibiotics, shouldn't I, even though they don't have any symptoms? So it's really important to know that white cells in the urine is also very common. So in a young female, about 32% will have white cells with no symptoms. Pregnant female, it can be up to 30 to 70%. Women with diabetes, 70%. Elderly patients with instrumentation, Foley catheter, 90%. Dialysis patient, 90%. As you see, it's really common to have white cells also in the urine. If there's no symptoms, really should not be giving antibiotic just for white cells in the urine. If we step back and think about why do you have white cells? Yeah. White cells can be because of infection, but also because of inflammation, irritation, other reasons as well. So it doesn't only happen because of infection. So it's really important to make sure we don't treat patients when they have no symptoms just for white cells in the urine.
Yeah, that's great. Yeah, I think that you know, the number of white cells in the urine is one of the best things we have in combination with having symptoms. Yes. But because it's there's no clear answer here is what makes this so tricky. Is that you know, there isn't one thing you could look at and say, I'm just looking at this. So you have to kind of look at everything together. So yeah, that's great.
So in 2019, we had updated guidelines from Infectious Disease Society of America, clinical practice guidelines for management of asymptomatic bacteriuria. So we're going to go over their highlighted points and the important points from this guidelines. So first question is, should asymptomatic bacteriuria be screened for treated in pediatric patients? So this committee, a large committee from all over, and nationally, internationally, they said in infants and children, we recommend against screening for or treating for asymptomatic bacteriuria. Should asymptomatic bacteria be screened for treated for healthy, non-pregnant females? So in healthy females, in healthy premenopausal, non-pregnant women, healthy postmenopausal women, we recommend against screening for asymptomatic bacteriuria. So we should not be getting urine to look for bacteria in the urine.
Yeah, and I think that question earlier was a good question because, you know, we'll see patients that come in, it might be a 92-year-old female, and they'll come in saying, I'm fatigued, I'm tired. And they'll say, we'll find out the cause. And then they'll grow some bacteria in their urine, and they'll say, you have a UTI. And they'll say, I don't have any frequency, urgency, dysuria. And they'll say, oh, yes, you do, and we'll treat you for it. But if you just randomly screen people, a portion of them are going to have bacteria, a portion of them won't, and a portion of them will have bacteria sometimes, and then sometimes it'll go away and come back. And there's no benefit to treating them, and there's actually harm to treating them because you're getting the bad parts of the antibiotic. So it's important not to test unless you have the intent to treat.
Should asymptomatic bacteria be screened for and treated in pregnant females? So in this case, in pregnant women, we recommend screening for asymptomatic bacteria, and we suggest a urine culture collected at first of the initial visit early in pregnancy. There's insufficient evidence to recommend for or against repeat screening. But if a pregnant woman does have asymptomatic bacteriuria, we suggest 4 to 7 days of antimicrobial treatment rather than a short duration. In this case, it's really important to do screen. There are exceptions, so we're going to tell you the exceptions. Pregnant women should get screened. If they don't, and they have asymptomatic bacteria, studies show they could go into preterm labor and have bad outcomes during their pregnancy. So this is the one time, and there's a couple more instances we should screen.
Yeah, and they're also at higher risk of pylo, I think, too,
yes,
right?
Yeah.
Yeah, so this is one case where you would screen for asymptomatic bacteria. Should asymptomatic bacteria be screened for and treated in functionally impaired older women or men residing in the community or in older residents of long-term care facilities? So in older community dwelling people who are functionally impaired, we recommend against screening. And in residents of long-term care facilities, we recommend against screening.
So again, so this is important to know, elderly patients, long-term care, we should not be screening. So we have a question. 26-year-old female who's currently pregnant presents to her OBGYN for a first trimester visit. Urine culture is ordered and obtained as a screening, and currently patient has E. coli, more than 100,000 colonies, which is pan-susceptible, really friendly E. coli. She has no symptoms of urinary tract infection. What will be the next step in the management? So A, give 5 to 7 days of oral antibiotic targeting this E. coli. Tell the patient it is asymptomatic bacteria, no treatment needed. Repeat urine culture today. Recommend cranberry juice, bladder irrigation with gentamicin. So what do you all think the answer for this patient would be? If you don't mind putting it in the chat or unmuting yourself.
So she's a pregnant female with asymptomatic bacteria.
Thank you, Valerie. Yes, A, give 5 to 7 days of oral antibiotic targeting the E. coli. Excellent. So fifth recommendation, in older functionally or cognitively impaired patients with which non-localizing symptoms distinguish asymptomatic bacteria from symptomatic UTI. In older patient with functionally or cognitive impairment with bacteriuria and delirium, and without local genitourinary symptoms or other signs of infections, fever, hemodynamic instability, we recommend assessment for other causes for observation and not rather than antimicrobial treatment. So what they're saying is, if you have elderly patients who comes in with like delirium, dementia, please look for other reasons before we blame this on the urine. A lot of times, many elderly patients, when they come in with mental status change, but they don't have fevers, the study shows a lot of times it's dehydration and electrolyte imbalance. So making sure we are looking for other causes as well as other sites of infections before we go to urine as the source.
Yeah, and sometimes when they get treated, you know, they'll come in, they'll be getting treated, we'll get consulted, and their family members will be there, and they'll say, oh, they were getting antibiotics and it seemed like they were getting better, and then today they seem like their dementia is worse. And it kind of shows that even though they're getting antibiotics, their mental status continues to fluctuate and go up and down, and it's not helping. And sometimes it takes family members, you know, getting antibiotics to realize that it didn't help at all. And
yeah, and just puts the elderly patients at high risk for C. diff, resistance, and drug adverse reactions. So really, really important not to do that. 6, should patients with diabetes be screened for or treated for asymptomatic bacteriuria? when they are not able to communicate that they have symptoms, how do we assess for that? Yes, great question, Valerie. I think when we have elderly patients coming into our clinics or hospital systems, and if their mental status change, what they're currently recommending is look for, like, do they have pneumonia? Chest x-ray, do they have fevers? Other reasons, do they have electrolyte imbalance? Do they need fluid resuscitation before checking the urine as the source for the infection? If it's just mental status change, but they have no signs of infection, usually it's not infection, it's something else. So that's what they're trying to say, let's not go to urine. If they're septic or septic shock, that's a different story. But if it's just mental status change, they're really strongly encouraging working them up for other reasons and not giving antibiotic and not checking urine.
Yeah, and more they're saying that a urinary tract infection is not a reason for confusion, which, it seems like it makes sense because patients with dementia and older patients are really the only ones that we'd ever say they get confused.
Yeah.
I mean, but yeah, it can be difficult, but it wouldn't be the first thing or the first place to go.
Yeah,
totally agree.
I like what you're saying. Think of this as the last thing, and let's make sure we look for other things first.
And especially if they've been treated over and over for the same thing and it hasn't helped in the past.
Yeah.
Yeah.
Should patients with diabetes be screened and treated? In patients with diabetes, we recommend against screening for asymptomatic bacteriuria. And should patients who have received a kidney transplant be screened or treated? So this is important to know. So if you received a kidney transplant, and the current recommendation is renal transplant recipient who have had renal transplant surgery greater than 1 month prior, we recommend against screening. So what that means is if you got a transplant, if it's less than 1 month, you could screen and treat. But if it's more than 1 month, they're saying you don't need to screen anymore. So that first 30 days is important after kidney transplant. You could screen and treat, but not after.
And then should patients who have received a solid organ transplant other than a renal transplant be screened or treated for asymptomatic bacteria? And then patients with non-renal solid organ transplant recommend against screening. And values and preferences. This recommendation places a high value on avoidance of antimicrobial use so as to limit the acquisition of antimicrobial resistant organisms and C. diff in solid organ transplant patients.
Just so that we know this, and for all of us to learn that when you have transplant, you're high risk for having resistant organisms because they've gone through so much antibiotics already and all these other immunosuppressive drugs, and high risk for C. diff. So if you have a solid organ transplant patient, it's really important not to screen and treat because we don't want to give them more resistance and put them at higher risk. Should patients with neutropenia be screened or treated for asymptomatic bacteriuria? So this is a really good question. So what they say is, let's say you have a patient with cancer, chemotherapy, they're neutropenic. In patients with high-risk neutropenia, absolute neutrophil counts less than 100 for more than 7 days following a chemotherapy or treatment for asymptomatic bacteria, we make no recommendation for screening for or against screening. So this data is still kind of not very clear. So I think here we have to use judgment. And if we do have a high risk patient with neutropenia and you're very concerned, in those cases, you could consider it. But what they say is their remarks are for patient with high risk neutropenia, managed with current standard of care, including prophylactic antimicrobial therapy and prompt initiation of antimicrobial therapy when they are fevering, if they're neutropenic. It is unclear how frequent asymptomatic bacteria occurs and how often it progresses to symptomatic UTI. We don't have real good data, but what they do say is if your neutropenia, if your neutrophils are low in those patients, we know some of them should get prophylaxis therapy until the neutrophils comes up, just in general. Or, when they're fevering and they're neutropenic, we should follow the neutropenic guidelines.
Yeah, so I kind of interpret that as it's not like every single patient. It shouldn't be on the protocol.
Yes.
For every single patient. Should asymptomatic bacteria be screened for or treated in individuals with impaired voiding following spinal cord injury? So this is a good question. Especially for veterans, like at the VA, I have patients with spinal cord injury, and they'll come in, and the question is, if they don't have if they can't tell you they have symptoms, or if they don't have symptoms since they have a spinal cord injury and a chronic Foley. And here it says we recommend against screening for or treating. So if they have a chronic Foley, nearly 100% of them are going to grow something. And the problem with that, especially with the younger patients that we get with spinal cord injury, they'll get antibiotics so frequently that the likelihood of them having resistant organisms where only IV works or no options are available, really increases. So if there's a young 30-year-old patient with spinal cord injury, they receive so many antibiotics sometimes that, by the time they're 50 or so, that they don't have any options really. So decreasing antibiotic use is really important, especially in those patients. So with those patients, try to look, do they have a leukocytosis? Are they having fevers? And sometimes those patients are with it so much they can tell you, I think I have a urinary tract infection because of the way I'm feeling. And frequently they are really with it and are really good with that. But it's really important to discuss with those patients the pros and cons of antibiotics and make sure that, if they do get treated, that they understand.
And just like all the other patients too, I like what you're saying, just let's also make sure we look for other reasons.
Yes. Yeah. Right. But if they come in with just a smelly catheter, sometimes there's some clinicians that would treat that, but it's really important not to do that, because when they need antibiotics, we want the antibiotics to work.
Should patients with indwelling urethral catheter be screened or treated for asymptomatic bacteriuria? So just like we talked about earlier, in patients with short-term indwelling urinary catheter, less than 30 days, we recommend again screening for treating for asymptomatic bacteria. In patients with long-term indwelling catheter, we recommend again screening for treating. So long-term or short-term, they recommend for both, not screening or treating, because remember that picture we showed earlier, you just get colonized super fast. Should patient undergoing elective non-urological surgery be screened and treated for asymptomatic bacteria? So not urological. And again, they say we recommend again screening for this as well.
So should patients undergoing a urological procedure be screened or treated for asymptomatic bacteria? So they recommend screening for and treating asymptomatic bacteria prior to a urological surgery. And the reason for that isn't to sterilize the bladder, but it's to keep the bacteria from going into the bloodstream and getting a bloodstream infection. So when they do the urological procedure, sometimes it's under high pressure. And they talk about pushing the bacteria into the blood, or there will be small cuts and there's a high amount of bacteria that will go into the blood from there. But it's just to keep the bacteria out of the blood, and you want to actually keep their bacteria that's there because that's their normal flora there. So we recommend that, if they're going to have a urological procedure, you would do a culture, before the procedure. And then when the culture grows something, you just give them a one-time dose at the time of surgery to keep the bacteria from getting into the blood and causing a problem. So, and sometimes we'll see people treating for several days and then reculturing and trying to sterilize the bladder. But that's not what's recommended. And sometimes they go through multiple rounds of antibiotics and they get resistance.
Yeah, so in this guidelines, they clearly outline in patients with asymptomatic bacteria who undergo urological procedure, a short course, 1 to 2 doses rather than more prolonged antibiotic therapy, and it should be initiated 30 to 60 minutes before the procedure. So making sure at your healthcare facilities, if you are doing urological procedure, part of your protocol should be, is it ceftriaxone, is it cefazolin, just 1 dose before 30 to 60 minutes before the procedure will really help with what Dr. Horn was saying. So then you should, and we see so many patients that get, just as an example, when they get antibiotics over and over again, and when we take the urine and we see E. coli growing, sometimes you could see the evolution of the E. coli month to month as they're getting antibiotic. They're getting more resistant, more resistant, and now you could see a friendly E. coli becoming an ESBL or CRE. So it's really important that not to do that.
Yeah, and when they come in for sometimes people will come in for their cystoscopy and they'll say, oh, you have a urinary tract infection, and they'll cancel the procedure and then put it off and recheck the urine and give them long courses. And again, it's like that 92-year-old lady I was talking about before. They'll say, you have a urinary tract infection. And the patient will say, really? I don't feel urgency, frequency, dysuria. And so it's really important to just recognize, oh, this is asymptomatic bacteria and a one-time dose before the procedure, and you don't need to cancel any procedure.
What symptoms would be by a long-term or short-term Foley catheter beside fever, which should you be watch for? Gather UA. Thank you. That's a really great question. So I think the symptoms when somebody has a long-term or short-term Foley catheter to look for, if the patient can give us a history, do they have suprapubic tenderness? Do they have any purulent discharge around the urethral meatus? Do they have fevers, chills, those type of symptoms? But other than that, if the patient comes in and they just have like mental status change or weakness, but no infection type of symptoms, I wouldn't go directly to the urine, but we should really look at what are the other causes. Because as you know, this is a really good question that you're asking, is that over 90 to 100% will be colonized, and we have to figure out who needs the antibiotic and who doesn't. So making sure we look for everything else, and if those are negative and patient has suprapubic tenderness, flank pain, purulence discharge from the urethral area, purulence in the folate, then those might be some indications that might be a urinary tract infection.
Yep. Yeah, I totally agree. And
they have bacteremia with E. coli and they have Foley catheter. You're like, then you're
leukocytosis, right?
Yeah, exactly. White count elevated. You were thinking infection. But most of the time when we see patients getting antibiotics, they have no symptoms. They have no infectious symptoms, but they got a urine culture, and now that patient gets treatment, unfortunately.
Yeah, and it's not very simple. It can be very difficult. And that's, talking to the family, talking to who the person that takes care of them at the long-term facility, seeing what changes have happened, why they're concerned. But it's not simple, and because it's not simple, it can be pretty difficult. Because really the easiest thing to do would just be to give them antibiotics, and that's why it's so tough.
So just summarizing the guidelines from 2019, what they're saying is indication for antibiotic for asymptomatic bacteriuria are pregnancy, renal kidney transplant 1 month after transplant, so the first 30 days, and urological surgeries. Those are the three things that we do a treatment for asymptomatic bacteriuria, and it's evidence-based. There's data. Pregnant woman at 12 to 16-week gestation, it prevents pyelonephritis, preterm labor, low birth weight. Impending urological procedure with mucosal bleeding is expected, prevents bacteremia, like Dr. Horn was saying, and this does not include placement of a urinary catheter. So we don't need to give antibiotic if you're just putting a Foley catheter in. This is for cystoscopy, uroscopy, invasive procedures within the first month of renal transplant. We're just repeating the same summary just to get that information. So our next question, what is the purpose of screening asymptomatic bacteria prior to urological procedure?
Oh, and we touched on this one. This is to prevent transient bacteremia.
Yeah. So preventing transient bacteremia, not nausea, not diarrhea, not to make the urologist feel better. Treatment is associated with, so when we give unnecessary antibiotic, unfortunately, we have resistance, increased risk of subsequent infections, UTIs, C. diff, and really bad multi-drug resistant organism. We're seeing a lot of them recently, a lot of ESBL, a lot of CREs, so really a lot of resistant gram-negative bacteria.
And this one, and so why did it cause an increased risk of subsequent UTIs? It's because you're wiping out the patient's good flora, and that makes it more increased risk of subsequent UTIs. And it's also a risk within the next few weeks of getting a urinary tract infection. Here, a 78-year-old man visiting with concern for recurrent UTI. Patient is visiting his primary care provider. He has no symptoms. What are the ramifications of unnecessary antibiotic treatment? And is it antibiotic resistance, C. diff, adverse side effects of antibiotics, increased subsequent UTIs? And we're going to give you the answer here. It's all of the above. So this is what was just discussed, was all those are things that can happen after unnecessary antibiotics.
And lastly, we get a lot of questions about surgery and should we screen urine and treat? So is there a value in getting urine cultures and treating before having orthopedic and spinal surgery? This study was done at Mayo Clinic and they changed their practice with this study. So it's really a good study to show. So what they did was they looked at urine culture, obtaining urine culture and not obtaining urine culture for hip replacement, knee replacement, spinal fusion, and lumpectomies. And what they noticed, and then they looked at if by getting urine culture, did we reduce surgical site infections? And once we treated the urine culture. So pre and post intervention, there was no real difference in any type of surgical site infection going up or down. There was no difference by treating the urine. So what Mayo Clinic decided, their conclusion is that ceasing pre-operative screening urine culture before non-urological surgery led to 86.6% reduction in practice among patients undergoing hip, knee, spinal lumpectomy without an increase in surgical site incidence. We all have these questions in our health system, concern about, do we need to treat the urine if you're doing surgeries to reduce surgical site infection? And what they have proven is you do not need to treat the urine to reduce hip infection, knee infection, spinal infection. We should really be not screening patients' urine prior to any of these procedures. And lastly, this was another major study that was done at the Veterans Hospital, where they looked at, is there reason to screen asymptomatic bacteriuria? They looked for heart surgery, thoracic surgery, and vascular surgery. And they looked at, is there a reason to screen and treat? And their finding is active antimicrobial therapy directed towards the asymptomatic pathogen, urological pathogen, was not associated with improvement in any measurable postoperative clinical outcome. The data of manually determined that surgical site infection, UTI, and positive wound and urine culture results were the same in the patients who were treated and those who were untreated. Data therefore suggests that there's no clinical utility in preoperative screening of urine culture for cardiac, orthopedic, or vascular surgery. So it's really important in our facilities we change practice. If there are protocols, changing them to not check urine before any of these procedures as well. And lastly, we wanted to share this flyer. This is from CDC, and this can be put in your clinics and other areas where avoiding treatment for asymptomatic bacteriuria. It's a really good tool if you need to hang it up or put it in areas where providers can see. And again, just a reminder, we have with urine antibiotic prescribing was not supported in 77% of patients with the urinary tract infection. So we really have to reduce the unnecessary antibiotic we're prescribing to help prevent C. diff and resistance. That is our last slide. Thank you for being with us today. And we open it up to questions you all have about asymptomatic bacteriuria, and any thoughts you all have on like pre-op, post-op, when to screen. Happy to answer.
And as far as protocols go, if you have protocols that you'd like us to review, or if you want help creating some protocols, we'd be happy to do that.
Yeah, but just make sure you all check your protocols and make sure they're
Yeah.
not screening unnecessary urine.
Yeah.
I think that'll be really helpful. Well, thank you.
All right. Thank you, everybody.
Have a good day. Thank you so much.